Good afternoon. I'm Dr. Lisa Tartaglia,
Dr. Bohn?
and we're here today to talk about prognosis and progression of disease.
Prognosis is basically the forecast, the evaluation by a physician to tell the patient and the family what the prognosis is going to be, what the forecast is going to be, what they think the future holds regarding this particular disease process. And for serious illness, receiving that information is really important for a patient, for a family, so that they can prepare. But it's also important for the physician and the team that's caring for that individual, because they want to stay on top of it. They want to anticipate what the needs of the patient is going to be based on what that anticipated change from that disease process is going to be.
Yeah, oftentimes patients get very worried when they hear that there's not a cure for their illness. However, lots of illnesses are still treatable. They're just not curable. There's a lot of chronic illnesses that now people live with for many years due to the way our medical system has changed and progressed. So there's a lot better treatments out there. But it's really important for all of us to treat the patient as a whole person, and to look at the illness and disease trajectory, and to have frank talk with the patient as far as what type of symptoms you're having, because that will help us prognosticate.
Each disease affects different organ systems. I mean, some of them will affect the same organ system, but many diseases, like Dr. T says, are not curable, but they are very treatable. Think about, when you go to the doctor, or if you've got a sore throat, certainly that, is cured. Think about a person that has appendicitis. The surgeon cures that. But most other disease processes are treatable. And so what we're trying to do is give medications or treatments or do procedures that delay the damage that might be done to the end organs, whether it's your kidneys or your liver or your eyes or your nerves, like to your fingers and feet, say for diabetes. We're trying to stall that off so that the body ages naturally together as a unit, and one organ system doesn't outpace in aging the other organ systems.
Exactly. And when you have different signs and symptoms of disease progression and these pathological changes that occur in your body, this in turn tells the physician that you have widespread illness. So it really, really helps us to look at the whole patient, and then we know what testing to do and what treatments, plans and protocols we should put in place.
So certainly it's frightening to be told that you have a disease that's not curable, but that doesn't mean that recovery, that care is not going to happen. And patients need to be reassured that the physician is just trying to be honest with them and tell them what is likely to happen. If they're able to treat an illness, is it going to recur? Is it going to come back? If it goes into what they used to use the word remission. We don't hear that word very much anymore, but we do need to inform the patients so that they can plan appropriately.
Mm-hmm. And, as we stated earlier, prognosis is determined by the physician. It's determined by the healthcare team. As us, we're palliative physicians, so we look globally at the whole patient. We can decide, which notes to really focus on. If the patient's having cardiac issues, obviously we want to collaborate with the cardiologist to understand what treatments they've been doing, because a lot of times patients don't even realize. Looking at their medications to see what classes of medications they're on, what has helped them, what has harmed them, and their side effect profile. So it's really important for us to prognosticate early in diseases and then have that relationship with the patient.
So the physician might say that your prognosis is excellent, might say it's good. Sometimes you hear the word it's fair. Sometimes you might even have to hear the word that the prognosis is poor. And of course, families are always devastated when they hear that the prognosis is grave or it's a terminal prognosis.
And it basically, the prognosis is determined not only on the historical data that the patients give to us as physicians, but also looking at lab values, as I said earlier, medications, and different changes in their functional status, cognitive status, and nutritional status really help us prognosticate the dying process as well as disease trajectory.
So when we give a prognosis, we're basing that information and try to qualify it that it's the average expected outcome. And there are so many factors, and we'll go through some of those in a moment, but so many factors that can affect that outcome. And we're not telling a patient this is exactly what's going to happen to you. We're trying to tell a patient this is what is typical. This is what the book says that this outcome is going to be. This is how other patients typically respond, because we do see patients that outpace that, and we do see patients who don't do as well as that. So we try to take all these factors that we're going to discuss into consideration when we talk about that prognosis, but we want patients and families to have the information that they need.
Yes, and I recently am taking care of a patient with heart disease, and he's very advanced in his illness. However, he and his family are very much in denial with his disease trajectory. So this week I was called to his home to evaluate him, and he called me saying, "I'm having a urinary tract infection. You have to come over. I want you to come see my urine." So I did go over later in the day. He'd already been assessed by his hospice provider. I'm his concierge palliative physician that comes in and kind of oversees the care for his family that live out of state. And yes, it's easy for me just to say, you know what, yeah, you probably have a urinary tract infection. You stopped antibiotics 7 days ago. He's had multiple infections, but also by the frankness of the blood that he had in his urine, and also other symptoms that he's told me. He's had less output, he has worsening edema, he has congestive heart failure. I did start to breach the topic of what if this is worsening of your kidney disease? What is it going to look like for you? He didn't want to hear it, but I told him slightly, gently. I explained it to his family. I sent emails to his out-of-state family, because I just want everyone to be aware that we can treat things such as an infection. But when we're taking care of chronically ill patients, they may not respond to that treatment as Dr. Bohn or I would, because we're healthy and we're walking. This is a non-ambulatory cardiac patient. So I'm not sure what's going to happen for him.
And sometimes that's difficult for families to understand. There's got to be another medicine. You're not giving them the right medication. But prognosis, part of that relies on all these multiple factors. Certainly for many diseases, particularly malignancies and cardiac and lung disease, there are multiple tables that a person can go to. But the disease state and the stage of that disease, particularly at the time of diagnosis, then the response to medications also influences our advice to the patients about that prognosis and the disease progression. Is the patient tolerating those medications? Is the patient responding as we would expect to those medications? So when we look at prognosis, we try to analyze multiple things to help that patient understand where they are in that disease process.
Has the patient had any injuries or recent infections? Injuries, sometimes, people take falls as very, not that serious, but they're very serious, especially if there's an injury related to the fall. That prevents patients from returning to their baseline. Infections, multiple infections show that the body's immune system is not fighting off illness well. They're not responding to treatments. Maybe their kidneys and liver are not functioning correctly to metabolize the medications.
To tag off what Dr. T is saying about infections, think about an elderly person in particular that maybe is living in an IL or an assisted living or a nursing facility. They are very prone to urinary tract infections, and they get to the point where maybe they don't respond as anticipated to that antibiotic, and now we use the term they're colonized with that antibiotic. And so if you go to choosingwisely.org and you look at some of the recommendations and some of the guidelines, it explains in common words why we don't do a test of cure. Many family members focus on, you treated the urinary tract infection and they've had 3 this year. I want to make sure that it's completely gone. We don't test for cure because many times these individuals have that bacteria in their body all the time, and we cannot just bombard them with antibiotics because the bacteria will get smart and they're going to become resistant and they'll get an infection that we cannot treat at all.
Exactly. That being said, there are patients that have different physiological age versus chronological age. So what I'm trying to describe to all of you is there are patients where we live in the state of Florida. We see some seniors that might be in their 80s and they look as if they're in their 60s. They're out playing 18 holes of golf, swimming on a swim team, on a softball team. It's pretty amazing. They live a very good life. And
pickleball.
Yeah, pickleball too. That's really so they live a great life, and you would never tell that they are their age, or you would never be able to tell that all their medications are on until there's a setback. And then there's other patients that unfortunately have had a more complicated medical history. Well, be it could be by them not taking care of themselves. They may have underlying mental illness that has prevented them from seeing that they have pathological problems in their medical care. Um, and these type of patients, they advance far quicker. And I'm sure Dr. Bohn sees
more rapid than what would be expected. When I was in the
Mhm.
Midwest, I might have, farmers that were coming in that were in their mid 80s or even 90 years old that are, still working on their farm and taking care of a few cows, and they look like they're in terrific shape. And then I would have other people come in that maybe were, late 60s or early 70s, and they looked at as old as what you would think the 90-year-old farmer would look. So there are so many factors in the chronological age versus the physiological age that a lot of people just don't realize.
Right. The other thing that we have to look at is weights. Weights can be good. It's good to have a healthy weight, but some diseases, if you're obese, it makes the disease progress. Like something like a chronic obstructive pulmonary disease or even heart disease. If you're carrying a lot of extra weight, it puts your body in stress all the time. You're in the flight or fight, so it will advance your illness.
But if you've got, I'm going to interrupt, if you've got a patient who doesn't have a good appetite and their weight is too low, then they're at risk because they've got muscle loss, they've got
Exactly.
sarcopenia, then they're more frail and their weight's not good. So we don't want the weight too high, and we certainly don't want the weight too low. We want to keep those people more in that middle range. And I like seeing patients, not at what the old insurance tables were. I like seeing
Yes.
patients have a little bit extra weight. I like seeing that BMI between 23 maybe
hmm
and maybe 28 or even 29, rather than seeing them over 35 or seeing the BMI under 21. I really worry when I start seeing a patient's BMI less than 21. I worry about their prognosis.
Also, their appetite can change. That's a really telltale sign for prognostication. If their diet had to change, for example, if they're eating regular food but now they're choking on their food, and they have to eat softer foods, smaller amounts, these are all signs and symptoms that physicians should be looking at to prognosticate for the patient.
And they can certainly affect their activity. So
hmm
activity is part of our prognostication, and frailty.
Yeah,
Frailty
frailty is big.
it's an important independent risk factor, and we'll talk about frailty on its own because it is so important. What that means, how frailty is looked at, how it's determined. But weight, appetite, activity, and that impact on frailty are definitely parts of that prognostication process.
Yeah. Also, the environment in which we live in, that's really important. Is our patients smokers? Do they drink alcohol daily? Are they illicit drug users? All these environmental factors play a part in the prognosis and disease progression.
Do they have help at home? Do they have
hmm
somebody that will either go with them to get groceries or bring them groceries on a regular basis? Do they know how to access the internet and technology, and can they access, for travel to, get to the store? So the environment is part of that impact on the patient's health and their prognosis.
Right. And a lot of times people don't look at that. And
Hmm.
it's really important for us. We make house calls. So
Hmm.
when you go into somebody's home, you really can get a good assessment of the environment.
Hmm.
So they might be speaking to their loved ones. Oh yes, I'm doing this, I'm doing that. And then when you go and you see, how their house, and if it's well kept, if
Hmm.
there's smells of urine, meaning that they're soiled and they're not able to get to the bathroom, it really tells a lot.
Are they getting good skin care?
Mhm.
Do they have pets that are well behaved, or are the pets maybe jumping on them or
Mhm.
causing skin injuries? Maybe the patient doesn't smoke, but maybe the other household members smoke, and they smoke, in the patient's presence, and it causes their disease process to not be well managed.
Absolutely. Also, the mental health of the patient, we briefly touched on that, but that's really important. A lot of times, as our diseases progress, our patients become very depressed because they lose a lot of autonomy,
Hmm.
and it's sad for them. This week I saw a patient. She was quite funny. She said, I never thought I'd be 96 years old and getting bathed by this gorgeous man with these big muscles. And I pay him and he doesn't get anything, and I don't get anything for this. And it was kind of funny the way she said it. She said, I'm a very humble, Midwestern lady, always have been a lady, but now I can't take care of myself. And I said to her, well, how old are you? She's like, I'm 96. I said, wow, you look like you're 76. Let him give you a bath. But she
Yeah.
never thought it would be a man giving her a bath.
So it can
And
cause a little bit of anxiety, a little bit of depression,
yes.
and that may be new onset. But if
Hmm.
they've had long-standing mental illness, whether it's something that they've really had trouble dealing with, maybe schizophrenia, but maybe they've had some
Absolutely.
intermittent depression or intermittent anxiety, and it certainly can contribute to their illness and their ability to access the healthcare system, their
Hmm.
ability to take their medications on a regular basis, and they may need extra support. Are they getting that extra support?
Right. And if their mental illness has been untreated for several years, and then they get a mild dementia, I see those type of patients, their illnesses, their dementia progresses more rapidly than someone with a stable past, no history of schizophrenia or bipolar disorder.
No, and I'm going to mention a 500-pound gorilla sitting in the corner. The skill of the physician that certainly plays a role in the prognosis of the patient. Now, I like to work collaboratively with the other physicians, the other disciplines, with nurses, the aides, the therapists, and even the pharmacists. And we've had a very complicated patient that we've been trying to take care of that has advanced cancer, pelvic mass in the patient, pain, bone metastases, and I've been working closely with the nurses on,
Hmm.
what are the symptoms, talking with the family because the patient's no longer able to communicate. What are their feelings? How do they feel their loved one is doing? The pharmacists about what medications we can do and how to advance those medications to provide just enough without too much because we don't want to overshoot the mark. So the skill of the physician and the physician's willingness to work with those other disciplines can definitely play a role in that patient's prognosis.
Yeah, and not only the ability of the physician to work with different disciplines, but I also think, Dr. Bohn, we need to talk about their ability to work with the patient and family. So there's so many physicians that are so tired. I'm not sure what it is, and they just don't want to take the time to speak to the patient and family. So it's just it's one-sided of this is what I learned in the books, and this is how I'm going to treat this. And you have to look at each patient. We're osteopathic physicians. We learn from day one to treat the whole patient. And I think sometimes I know for myself that I can doubt myself, and I feel that because of being an osteopath, I treat my patients better than some of my colleagues that do not have that holistic approach.
It's caring for the whole person, caring for the whole individual, and the family is part of that
Mhm.
individual's process.
Yeah.
So also, as part of this prognostication, it can be affected by other things, whether they're anticipated or
Hmm.
not, and whether they're related or not. And we'll give just a couple of examples like that. So if you've got a patient that maybe has a diagnosis of a lung cancer, you might expect that person, it might be anticipated for that individual to have shortness of breath.
Right.
Okay. But if the patient has lung cancer, it might not be something that's anticipated for them to become anemic.
Right.
So sometimes a disease process has something that's anticipated and that's not anticipated.
Right. And we do our best to try to teach the patients and families what to expect, but sometimes even us as physicians, we're surprised at the way the disease progresses. So a lot of times, like we know breast and prostate cancer, there's a mnemonic that we learn in first 2 years of medical school. It's on our boards that there's metastasis to the bone, and we know as hospice and palliative medicine physicians, bone mets is
Painful.
painful and incredibly hard to treat. There are a lot of treatment options out there, but it is very hard. You have to be very aggressive in the management, and sometimes we receive the patients late in the disease and their pain is already out of control.
If a patient can go for radiation therapy, certainly that can definitely reduce bone metastatic pain that is related to that prostate cancer process. But if they're homebound now, it may be too difficult for them to get out of the house to treat that. So with prostate and breast cancer, we can anticipate for a related problem of that bone pain. But those patients might have maybe a heart problem, and that's not something that is really related to that prostate or breast cancer. It's an unrelated and medical illness.
Right. And what Dr. Bohn means by that is they may have a history of cardiac illness that was very well managed. So they didn't have symptoms, but once they got diagnosed with a cancer diagnosis, and as that progressed, the symptoms then start to show up.
So as you can see, it gets really intricate and really convoluted pretty quickly when you try to figure out how did they come up with this prognosis for me? Why did they say that about me? I see other patients, or when I look it up on Dr. Google, it doesn't have the same thing, because the physician's taking all of this information into account. And so they're trying to individualize it for you. It's not a square peg being pounded into a round hole. They're trying to individualize it for you.
Yeah. And unfortunately, some of our physicians are not completely honest. They may only tell a portion of the truth, a third of the truth, sometimes, because they don't want to add burden of truth. They don't want to be discouraging to the patient. And sometimes
we don't want you to be mad at us. We don't want the family to just be, taken aback. And I think sometimes Dr. T and I find that a lot, because we'll go in and we'll have been asked to evaluate a patient or provide a consultation, and we provide information, and we're greeted with this response of, no one has ever told me that. I've been seeing my specialist for this many years, and they've never mentioned these things. You're the first doctor that has told me that. No physician has ever mentioned these things to me. And, we always wonder, did they really not get the information, or did they not hear the information?
Yeah.
So sometimes it's that talking and listening process.
Yes, and sometimes you have to hear the information multiple times.
Or different ways.
And yeah, in different ways. And what I've always done after I've been met with anger early on in my career, I learned very quickly to read the room. And what I mean also by reading the room is I ask open-ended questions to the patients and families of, what do you know? So then I know how to address what I know by looking at the chart and by looking at the overall patient.
And I always ask them, what would you like to hear? I don't want to tell you something that you don't want to hear.
Absolutely.
I will promise you that I will always be honest with you, but I don't want to mislead you. I don't want to lie to you. And I certainly don't want to provide you false hope.
Exactly. I think it's so important to not provide false hope, but also, some patients like to live in denial, and we just have to let them.
Yeah.
And as long as someone is aware, if there's family aware, so they're able to come into town if they want to say goodbye to their loved one, that's great. And I always say, even with the patients that live in denial, I think a lot of times they do know, because their body is shutting down. I've never been dead and rejuvenated back to life, but I would imagine as their body's shutting down, they have some awareness.
Some awareness.
So as you can see, this topic is really
really broad.
Yeah. And each illness has its own
table
and set of factors. So we think we're gonna take this down to several notches and go illness by illness, system by system, just to kind of break it down for all of you. Help for better understanding. I feel like knowledge is power.
Yeah. And you may have a particular disease that you're interested in and may not want to listen through all those other diseases. Yeah. We realize that not all of our content is for everyone. I've gotten several messages from people that, they really appreciated some of the videos, and they know of friends or family that have needed information from other videos, and they have forwarded that to them. So we appreciate that, and we don't expect people to, watch every video, but we want this material to be there and be available for people in a non-threatening environment of your own home and in your own timetable. So, providing this information to you to help you manage your symptoms and the system of healthcare. That we think that that's really important. We want you to be able to control your symptoms as best you can and have the best life that you possibly can for as long as you possibly can.
Yeah, our information that we're providing to you is not meant to be negative or to try to bring you down. We just feel that more information we give you, the more power you have to prepare, and then it will allow you to have ask the hard questions to your medical team in hopes to gain better symptom control for your progression of illness.
We want to normalize the dying process.
Mm-hmm.
It does happen. It is real. It's just like taxes. It's going to come for all of us. And so we want you to be as comfortable as possible. We want you to be as well informed as possible. And we want you to have as good a life as you possibly can for as long as you can. And not to fear these things so much that you don't even ask about it.
Yeah. We'd like to thank you all for joining us this afternoon, watching our video. Please add any comments to this topic, because we're going to be unpeeling layers of onions to talk about all the systematic illnesses and all the
all these different disease processes. We do have many of these, if not all of them, but many of these are now available on our podcast, and that's on several different platforms. So check for the You Only Die Once on the podcast system that you're familiar with.
So if you cannot watch us on video,
please listen.
Please listen. Are you out taking your walk, driving to work?
Yeah. If you've got a loved one, or if you yourself are facing serious illness, we really want to try to provide some assistance and help.
Thank you, everyone, for joining us.
Bye.